Good evening, ladies and gentlemen. Welcome to another exciting episode webinar of Blood, the Life Savior. Today is episode 17, so more than 1.5 years already running. And today we have a very interesting unusual case of parapheresis. And the presenters are from NRS Medical College, Calcutta, one of the oldest medical college in the country. A warm welcome to our course director, who is the brain behind, who are the brain behind this long-running episode in the field of hematology, Professor Dr. Viju George sir and Professor Dr. Joseph John sir. Thank you very much for your continued guidance and always advising us how to go about it. As you know, we start on time and we finish on time. Normally, it is for a period of 1 hour, and we try to make it very, very enriching. Both our course directors have guided me to be very brief in their introduction. They need no introduction, ladies and gentlemen, to be very honest with you. Professor Dr. Biju George, sir, Director, CMC Vellore, and what he epitomizes is number of patients who are treating, number of students who are now professors, assistant professors in various parts of India and world. And uh, sir is also Professor Department of Hematology at CMC Vellore. 300 plus publications, more than 6 books, chapters contribution, also developed various treatment protocols in aplastic anemia, and Sir epitomizes stem cell transplantation and bone marrow failure disorders. Our second course director, Professor Dr. Joseph Johnson, Professor and Head Department of Clinical Hematology, CMC Hospital, Ludhiana. I was lucky enough to meet one of his students very recently in Surat. So both our course directors are famous across the world for guiding and creating so many budding hematologists of the country. Thank you for your contribution to hematology, sir. May I request both of you to take it forward from here?
Thank you, Dr. Manoj, and good evening, everyone. So we have, as mentioned, we started this webinar series in January 2025, and this is the 17th episode. And today, our colleagues from NRS Medical College are going to be discussing an unusual case of parapheresis, extramedullary hematopoiesis, and thalassemia. So I would request Dr. Supratim Ghosh to go ahead with the case presentation. Then Dr. Shipla will discuss the case, and subsequently we will take questions from the entire group. So go ahead, Dr. Supratim.
Thank you, sir. And a very good evening, my respected teachers.
Yes, Dr. Supratim, you are audible.
And is my screen visible, sir?
Yes,
Yes.
you are visible. So, Dr. Supratim is the resident. I am from Professor T.K. Dulai from the Hematology NRS Medical College. So, basically, this is the important, interesting case we'll be discussing by the brilliant PDT, Dr. Supratim, and also the case will be discussed by our another brilliant hematology, Dr. Sipla Roy. So she will be the discussion of the important cases. I think that is the people are more focused on the hemato-oncology and related to the different cancer, bone marrow transplant, and also the cellular therapy. I think this is the bread and butter of the different benign hematology, particularly the thalassemia, particularly the plastic anemia, anemia sector, the platelet, the hemostasis, and the thrombosis sector. I think this is the very, very important aspects that the majority of the young hematologists, they are not getting interest. There is a variety of the reasons for that. I am not going into the detail, but today we will be discussing an interesting case related to the thalassemia. So I am requesting.
I think go ahead, Dr. Supratim.
Okay. Thank you, sir. With all your permissions, I'll be presenting my case. So, coming to the chief complaint, so my patient is a 30-year-old male resident of Joynagar, that's near Kolkata in a nearby district, and he presented with the chief complaints of weakness in bilateral lower limbs for last 1.5 months duration. And along with that, he also complains of urinary incontinence for last 1 week duration. So now coming to the history of the present illness, the patient was in his usual state of health approximately 1.5 months back, and he was able to perform his routine daily activities independently. But gradually, he noticed weakness in both the lower limbs. Initially, first he experienced the difficulty while on walking, and first in the one limb, and over the last 1 week duration, he also noticed weakness in the right limb also. First, the weakness which progressed very slowly, and first only during the difficulty in walking only he presented, but later he noticed difficulty in performing other activities also. And he also described along with that the stiffness in bilateral, that he feels stiff or both the lower limbs while walking, and he also complained that his lower limbs felt heavy, and over next few weeks the weakness progressed to such an extent that he required support while walking. And at the same time, he noticed imbalance while walking and having difficulty in initiating any gait. And for the last 1 week duration, that's prior to admission, the patient also complained of bladder involvement in the form of that urinary incontinence, and he was unable to voluntarily control his urination or micturition, and subsequently he was catheterized outside. And there was also associated bowel dysfunction in the form of uncontrolled passage of the stools. Now, coming to the negative history, so there is no history of any weakness in the any of the upper limbs or any upper part of the body. There is no history suggestive of any cranial nerve involvement, such as drooling of the saliva, or any hoarseness of voice, or any nasal regurgitation of the foods, or a doubling of vision, or any drooping of the eyelids, or any facial numbness, or any hearing loss. There is no history of any altered sensorium, or any involuntary movement or seizure-like activity. No history of any loss of consciousness. There is no history suggestive of any cerebellar involvement, like swaying while walking, or any involuntary movement, or any speech abnormalities. There is no history of any girdle-like sensation, or any root pain, or any radicular pain. There is no history of any preceding trauma to the spine, or any history of fall from height. There is no history of associated preceding fever or vaccination. There is no history of any recent respiratory infection, diarrhea, or there is no history of any breathlessness or any respiratory muscle weakness. Now, coming to the past history, the patient is a known case of some hematological disorder, which was initially diagnosed when he was at 9 years of age, and for which he intermittently required blood product transfusion, red blood product transfusion, and he also complained of easy fatigability on doing daily activities since then, off and on, and which is usually relieved on taking rest, and the symptoms transiently improved after taking blood transfusions. And initially he needed blood transfusion once in every 6 months approximately, but the transfusion requirement has increased over the last 1 year, while he required almost one blood transfusion every 2 monthly interval basis. And the last blood transfusion happened 15 days back. And the patient, on inquiry, the patient also gives history of intermittent yellowish discoloration of the eyes on and off since the same duration. There is no other specific past history. The patient is a known case of hypothyroid, which was diagnosed approximately 10 years back, and for which he is on regular medications. And there is no history of any diabetes mellitus, no history of any hypertension, and no history of any contact with tuberculosis, and there is no history of any personal history of seizure disorder or bronchial asthma. Treatment history, I have already mentioned the blood transfusion details. Approximately 30 to 35 units he has been transfused since the age of 10 years, and he is taking along with some tablets on irregular basis. And coming to the personal history, the appetite is adequate. The patient takes mixed diet, and the sleep is also adequate. Bladder and bowel dysfunction I have already mentioned in the present illness. Now, after catheterization, it's slightly improved, and there is no history of any high risk behavior, no addiction like smoking or alcohol abuse or any substance abuse. Family history, there is no family history of any similar illness or any neurological illness or any hereditary known disorders. And coming to the socioeconomic history, as per the modified Kuppursamy scale, the patient belongs to a lower middle socioeconomic status and he lives in a pakka house and he has access to the drinking water. So now coming to the summary of the history, my patient, that is 30-year-old male, a case of anemia on recurrent blood transfusion since 10 years of age and known case of hypothyroidism on treatment. He presented with insidious onset, gradually progressive, asymmetric weakness involving both his lower limbs, resulted in difficulty in walking over the last 1 month's duration, and along with that bladder involvement for last 1 week duration, without any history suggestive of any sensory or any upper limb weakness, without any history of any preceding trauma, fever, root pain, or any vaccination. Sir, should I proceed to the examination?
Yes, please. Please go ahead.
Okay. So now coming to the general physical examination, the patient was examined approximately 1 month back, and on the day of presentation, actually he was examined, and the patient was conscious, alert, and cooperative, and well oriented to time, place, and persons. He was moderately built and nourished. His faces was normal. And coming to the vitals, his pulse vitals were within normal limit. And on head to toe examination, he was moderate pallor was present. However, there was no jaundice, edema, clubbing, or any cyanosis. There was no any lymphadenopathy. Skin and genitalia were within normal limit. Now, based on the history and general examination, I have examined the neurological system first. So, coming to the CNS, higher mental status examination. Higher mental status, the patient was conscious and oriented, speech, memory, and behavior was appropriate. Cranial nerve examinations all were within normal limit. Now, coming to the motor system examination, there is no obvious wasting or fasciculation. Tone upper limb bilateral, the tone was normal, but there was increased in tone with spasticity in both the lower limbs. And coming to the power, upper limb powers are within normal limit 5 by 5. In the lower limb power, hip joint, knee joint, and ankle joint, all the muscles in the especially in the flexor group and extensor group, the power were 3 by 5. That is decreased. And coming to the cerebellar sign, some finger nose test was normal, but heel shin test actually it was very difficult to perform due to the weakness. Now coming to the reflexes, superficial reflex, abdominal reflex were present bilaterally. The Babinski sign was positive, and that is the plantar was bilateral extensors. And coming to the deep tendons reflexes, the knee jerk bilaterally and ankle jerk bilaterally were 3+, that is exaggerated. However, there is no involuntary movements or any fasciculations observed. Now, from the sensory system, the sensory system, all the fine touch, crude touch, and pain, temperature, joint position, and posterior column sensors, including the vibration sense, all were within normal limit, and there were no definite sensory upper level could be elicited because there was no sensory loss at all. And coming to the gait, there was any spastic scissoring gait was present, and at that time the patient required support while working. And coming to the autonomic system, there was urinary incontinence, probably urine type of bladder, and the bowel dysfunction was present initially, which was improving. Now coming to the other system examination, lymphoreticular system examination, the pallor and face is already described. So there was moderate pallor and no lymphadenopathy. There was no sternal tenderness. And coming to the abdominal examination, there was hepatomegaly in the form of liver was palpable almost 2 centimeter below the right costal margin, which was firm and smooth surface and regular border and firm in consistency, and left lobe was not palpable. And spleen was also palpable 5 centimeter below the left costal margin, which was firm in consistency, smooth surface, sharp border, and the splenic notch was appreciated. Now, review of other systems, that is the respiratory, cardiovascular, and abdominal system that were within normal limit. So now coming to the summary of the case from the history and the clinical examination. So my patient, that is 30-year-old male patient, a case of anemia on recurrent blood transfusion since 10 years of age and known case of hypothyroidism on medications, presented with insidious onset, gradually progressive, asymmetric weakness involving the bilateral lower limbs and resulting in difficulty in walking, and now the patient requires walking with support over last 1.5 months duration, and along with that bladder involvement for last 1 week duration. without any history of sensory or upper limb weakness and without any preceding history of any fever, trauma, root pain or any vaccination. General examination was notable for moderate pallor only, vitals were within normal limit, jaundice were absent, and neurological examination revealed upper motor neuron type of spastic paraparesis along with bladder involvement. And lymphoreticular system examination revealed moderate hepatosplenomegaly, and the review of other systems were within normal limit. So, based on my history and clinical examination, my clinical provisional diagnosis was it's a case of spastic paraparesis secondary to some compressive myelopathy, probably thoracic region, and thoracic spinal cord involvement was there, and probably the lesion was extradural and it is compressive in nature. And etiologically, probably my etiological diagnosis, it could be a case of extramedullary hematopoiesis and secondary to chronic hemolytic anemia and causing compressive myelopathy. So this is my case presentation. Should I stop wait
No,
here
no, no.
or?
My suggestion would be proceed with the discussion on your findings, laboratory findings, and then we will go to the discussion on the management.
Okay, sir. So now I am proceeding with the investigations. So initial routine investigations, there is a complete hemogram which revealed the hemoglobin of 7.9 with a low MCV, and other platelet count was slightly on the lower side, and Paxil following 22%. Renal function test and other biochemical parameters and electrolytes were almost within normal limit apart from calcium, which was borderline high, and liver function test revealed unconjugated hyperbilirubinemia with normal AST, ALT and alkaline phosphatase, and the proteins were within normal limit. Now we proceeded with the further one HPLC were done, which was suggestive of beta thalassemia measure in the form of HbF was 80.80%, and iron profile ferritin was high 802, and thyroid profile at present were within normal limit. And the chest X-ray was done, which was not very significant. However, due to the suspected myelopathy and deletion, pictures I have tried to incorporate it here, and which showed bilateral multiloculated paravertebral soft tissue muscles with extension to the dorsal epidural space with variable extension from D2 to D11 vertebral lesion, and it resulted in compressive myelopathy. So, and the T1 moderate and T2 hyperintensity, which was strongly in favor of extramedullary hematopoiesis. So, my final diagnosis would be it's a case of non-transfusion dependent thalassemia with thoracic compressive myelopathy secondary to extramedullary hematopoiesis and presenting in compressive myelopathy or spastic paraparesis. Thank you, sir. I'll rest my case, sir.
So is Dr. Shipla going to discuss management, or who?
Yes, sir. The patient presented as beta thalassemia intermedia, like because patient was previously transfused almost 1 to 2 times per year, but recently he is receiving blood transfusion very frequently and presenting with paraparesis. Then only we examine the patient as well as done all the investigation, and then he was diagnosed as extramedullary hematopoiesis in case of thalassemia, and he is beta thalassemia homozygous patient, but he was not on regular transfusion requirement because he did not require any regular blood transfusion. So my question is, in like thalassemia intermedia patient, for thalassemia intermedia patient, what you are usually giving the medicine in such patients?
Yes, and actually for intermediate or non-transfusion dependent patients, actually the chances of extramedullary hematopoiesis is more in this case is more than the transfusion dependent thalassemia patients, ma'am. And the mostly due to the ineffective erythropoiesis component, and which resulted in the extramedullary hematopoiesis. So our should be can be the HbF inducers and the cytoreduction, that is the hydroxyurea we can keep, and adequate transfusion to keep the optimum hemoglobin level more than 10. That should be our goal.
Yeah, I think Dr. Tufan here, Dr. Supratim, apart from your the extramedullary hematopoiesis, so what made the other differential diagnosis of the spastic paralysis in a background of the thalassemia? So this is for the resident question. So it is not synonymous with the extramedullary hematopoiesis. There is a lot of the other two different still diagnoses might be there. So what is your guess? The extramedullary hematopoiesis is the one of the important thing we always listen. That is very good. So any other possibilities there in the Indian context?
Yes, extradural causes, it could be on the Pott's paraplegia or carry spine. That could be a that is very common in Indian scenario, sir. And
Very good.
then, sir, thalassemia associated with many bone disease or bone disease in thalassemia that can result in prolapsed intervertebral disc that can cause extradural paraparesis like lesion or compressive myelopathy. And
Right.
and any local abscess or hematoma that can also, sir, lead to extradural lesion that resulted in this type of spastic paraplegia.
If there is a spastic paralysis in the background of the thalassemia, so should not forget the other differential diagnosis also.
Yes, sir.
Is over to Dr. Supradeep.
So, Supratim, so you had this patient, you would start hydroxyurea, but you have a patient, the hydroxyurea takes time to act, but you've
Yes,
got a
sir.
patient who's got a progressive paraparesis.
No, actually, sir, the patient, when I was talking to manager, we actually treated the patients with actually the patient was symptomatic. So we had actually given radiotherapy to the patient, and the patient actually symptomatically much improved. We have actually advised for the patient took 10 sessions of local radiotherapy at 2 gray. And after that, actually, within almost 3 to 4 weeks duration, his weakness has much improved. And along with that, we have given optimum transfusion to the patient and kept the hemoglobin around 10 to 11 free transfusion hemoglobin, sir. And we started hydroxyurea as well, sir.
And another thing that sometimes the neurologist is always give the advice that if the patient has a little bit of the inflammation is there around the cord, if your the MRI is suggestive of any inflammation around the cord edema is there. So this sometimes the prefer to give steroid also along with your radiotherapy, right?
Yes, sir. Yes,
Because
yes,
sometimes
yes,
the
yes, yes.
radiotherapy with increases your spastic paralysis.
Yes, sir. Initially, yes, sir.
So during that point of time, you should also give the short course of the steroid. Otherwise, your the paralysis might exacerbate.
Yes, sir.
Joseph, will you take this forward?
And Dr. Supratim, there you have shown that calcium level is 11.8 in this patient.
Yes, sir.
Okay.
Calcium. Yes, ma'am.
So what you have done for this patient?
Actually, for that reason, we have evaluated the other causes of hypercalcemia, and we have ordered actually the vitamin D3 and the intact parathyroid level. So, vitamin D3 was actually within normal limit, and parathyroid level, that's report is awaited, ma'am, actually. But the patient was otherwise asymptomatic. It was borderline albumin. After albumin correction, it was only borderline high, just 11.8.
Okay.
So some hydration we have given, and we plan to repeat the calcium after 1 month duration initially.
Okay.
Right.
Is there any role of giving zoledronic acid in thalassemia patient?
Chlorindronic acid in your the NTDT or
Hypercalcemia.
any other TDT.
In symptomatic hypercalcemia with thalassemic bone disease, sir, we can give bisphosphonates can be given, sir.
Nice. We recently conducted a beautiful study in some of the PDT did a study in
Thalassemia patient.
NRS. There is a role of zoledronic acid in the thalassemia, the longitudinal follow-up. There is a
Along
definite
with
role of
DEXA
the
scan.
there is a definite role. After the 10 years of the age, you should serially do the DEXA scan. At least yearly, you have to do the DEXA scan. If you're the suggestive of your the severe
That's
osteopenia and osteoporosis, so in that scenario, you have to give zoledronic acid. Usually the zoledronic acid they recommended you can give every 3 to 6 monthly, but usually we follow the 6 monthly, and the result is very good because the osteoporosis part is improving and your the bone stability will become improving. The risk of fracture is also improving. I think there is a role of your the zoledronic acid
hyaluronic
also.
acid.
in case of this. But here the dose is sometimes the people are using the dose of 3 mg. In the multiple myeloma, we are using the slightly higher
Oh,
doses, the
I do.
3.5 we are using, but in the case of your the thalassemia, the 3 mg you can also use it.
Yes, sir.
Dr.
Noted.
Sipla, any other question or any other comment?
And sir, in NTDT patients or thalassemia intermediate patients, there is any role of thalidomide, Dr. Supratim, and how much dose you will provide in those patients?
Yes, sir. Some studies are there, and we're also going, especially in the intermediate E beta thalassemia patients, the dual HbF inducers or thalidomide plus hydroxyurea or the thalidomide alone. They actually increases the decrease the blood transfusion requirement in this group of patients. And dose is usually we start with the 50 to 100 mg if the patient can tolerate, and there is slight increase of thrombosis, so we monitor the patients accordingly.
And you will give aspirin in every patient or not,
Yeah,
along
yes,
with thalidomide?
yes, ma'am. If there is no significant bleeding, so we are giving thalidomide along with aspirin along with thalidomide because it increases the VTE risk. So we
I
are
think
giving
I
it.
think there is a little controversy there in terms of the aspirin. So we have been recently published a big series of the thalassemia, the original article around more than 300 patients. And in that paper, we have been clearly shown us that the thalidomide 50 mg becomes quite effective, and there is a decreasing of the transfusion frequency for more than 70% of the patient, and there is a the hemoglobin level increment is 3 to 4 gram is seen around the 30 to 40% of the patients. So overall around the 70 to 80% patient responded very well. And we have been not given any aspirin prophylaxis of the any of the patient except in 2 to 3 scenario. If the patient has a post platelectomy, if the persistent platelet count is more than a 5 lakhs. So in that group of the patient, there you can give the aspirin prophylaxis, but yes, you have to be very cautious, particularly in case of the NTDT, because risk of thrombocyte, the risk of the thrombosis is always there. So the nowadays the majority of the people they are writing the thalidomide in the NTD patient, and it becomes quite effective. There is a lot of the series have been also published. So the NRS Center have been published in the childhood also. So the adult publication is also there and the children publication is also there. So it is both the cases it is the quite effective. But Supratim, any other drugs using in the NTDT or the NTDT, it is not an NTDT, it is in the TDT that might increasing in the extramedullary hematopoiesis. Some newer drug is
Yes, sir.
there if you are using.
Luspatercept trial, in the luspatercept trial, they have shown that the luspatercept is as a group was associated with extramedullary hematopoiesis slightly more than the placebo group. Sir. So it is relatively contraindicated, luspatercept.
Right. So if the patient has a propensity to develop the extramedullary hematopoiesis or any in the serial imaging you find
Mm.
that there is some paravertebral mass is there, so you should be very cautious that that kind of the patient the luspatercept should not be used. So the transfusion, though currently this is approved for only transfusion dependent thalassemia, but sometimes it can seen in transfusion dependent thalassemia, but the extramedullary hematopoiesis is more seen in case of the NTDT rather than your the TDT. So here the Dr. Biju, any question, Dr. Biju and Dr. Joseph?
So, Supratim, you said about not using luspatercept. I agree. Is there any other drug that can be used? So, more recent study.
Uh,
There's a recent study in Lancet on the use of mitapivat, which is a PK
Mitapivat,
inhibitor.
mitapivat.
Yeah,
Ajamita
it is
pivot.
a PK inhibitor, but has been shown to be useful both in NTDT as well as TDT in reducing transfusion frequency. So I had a question for this patient. You said you've been transfusing regularly. So are you going to now treat this patient like a thal major and transfuse monthly?
Sir, we have started hydroxyurea and we're looking right now the patient is we are just for last 1 month we have transfused 3 to 4 units of PRBC just to keep his hemoglobin more than 10 and simultaneously started hydroxyurea as well. And the patient is as symptomatically better, so we'll start planning to start actually dual HbF inducers as well, which might reduce his transfusion requirement.
As well as we
And
have to rule out the alloimmunization also, because you have to give phenotypically
Yeah,
matched blood transfusion.
phenotypical image. Yes, ma'am.
and you need to maintain your hemoglobin little bit higher level.
More than, I said,
So,
10 to 11 pre-transfusion we are trying to maintain, sir. More than
Correct,
10 at least.
correct. Joseph,
right.
are you there? Okay, since he's not answering, I think there are one or two questions in the chat. So the first question is, what is the explanation for no sensory involvement, given that there is bladder and bowel involvement?
Dr.
Mm,
Supratim, any you can give the answer?
Sir, probably is a from the extramedullary hematopoiesis, there is some mechanism that has been postulated that it could be the extrusion of the hyperplastic of the hyperplastic or hyperproliferative marrow. So it can selectively involve the motor tracts like the anterior horn cells and the autonomic tracts, and not the sensory pathways in the spinal cord. So that might be the reason that it selectively spared the sensory tracts, and there is no sensory involvement. That's why.
So the spinothalamic tract is inside, right?
Yes, sir.
So there is extrinsic compression is there, so they will be involving the more the motor tract.
Okay. The next question is, the ferritin is not as high as expected for a NTDT. Would you agree with that statement?
Uh, Ferritin was 800 approximately. Yes, not as high, but the patient has no history of that much blood transfusion in the past. So only 1 to 2 per year, and only in the recent times he received multiple blood transfusion over the last 1 year duration. He received 4 to 5 blood transfusions. Otherwise, only 1 to 2 per year he used to receive. And
Okay.
there
Okay.
could be, sir, associated iron deficiency as well, which is very common in our part of the country, sir.
And another important thing is that in NDDT there is increasing iron absorption also.
Yeah.
There is a role of the important hepcidin is there, right?
Yes.
So that might be play, and there is no correlation
I,
between
I,
the
I I
NTDT
think
and
that
the
is,
ferritin.
I, yeah,
Yes, yes, yes.
I think that is why this question was asked, because I think generally in NTDT, because of the increased
Increase
GI
absorption, yes,
absorption,
increase
we
absorption, yes,
generally
yes, sir.
find a higher ferritin than what is sort of expected for because of the number of transfusions. I think that is why this question was asked. So Dr. Chandran has asked question of any role of RT. Yes, I think they have
Yes,
explained the
sir.
fact that they actually gave radiation therapy for the acute phase to
Yes, sir.
make sure that the symptoms have improved. What is the total RT that you gave, the dose?
Sir, we have given 10 session of 20, total 20 gray, sir. 10 sessions, 2 gray each. So total 20 gray we had given.
And what was that dose based upon? Was it based upon clinical improvement, or was that the maximum dose that sort of that the
Sir,
radiation
as per the
colleagues said?
literature, sir, yes, sir, we have consulted with the radiotherapist actually, and sir, in the literature it was written that as high as 30 gray can be given. Low dose, but low dose is usually recommended. That's what the relative says. And in consultation with the radiotherapist only, we have finalized the dosages, and the patient actually got symptomatically improved, and now patient is able to walk almost without support. Yes, some limping gait is there, but some weakness is still persisting, but the patient is now able to walk, sir. So,
Okay. So all those who are listening, please, if you have any other questions, either you raise your hand or you please put it into the chat. Dr. Joseph, are there any questions from your side? So, what percentage of patients that you see with NTDT will present with extramedullary hematopoiesis, at least in your clinical practice? What is the percentage that you see?
extra.
The
Hello.
Dr. Supratim,
Doctor
what
Hello.
Supratim in the
percentage of
percentage,
patients
matlab in your
with
the
Sir,
NTDT,
in NTDT, sir, we have seen
what you've seen in your clinical practice, what
sir,
percentage present like this?
sir, we have seen in
We have
NTDT only 5 to 10%, but in literature said, sir, it is slightly higher, 15 to 20%, but we have seen in 5 to 10% cases only.
Okay, okay.
Hmm.
So, since I'm a transplanter, so I'll ask this question: is there a role of bone marrow transplant in NTDT?
Uh, hmm. Sir,
Is there a rule of bone marrow transplant and is there a rule for splenectomy? Two questions.
Sir, role of splenectomy is only if there is any other indications, like the patient developed any symptoms due to the splenomegaly itself. There is massive splenomegaly resulting in pancytopenia, which requires blood transfusions, not as per se to reduce the or to increase the hemoglobin. We are doing splenectomy for some other indications if the patient qualifies
So
only in
what
that
happens if, so let me ask you a question. So what if you have a patient who has failed hydroxyurea and thalidomide, and we know that most of our Indian patients cannot afford luspatercept or mitapivat. So what will you do for those patients? Will you do a splenectomy?
Sir, only if the patient is symptomatic or there is any increase in blood transfusion requirement, or if the patient has any features of hypersplenism like pancytopenia or any other symptom or splenic infarct. These are the indications, not as per se just splenomegaly.
So remember that if this patient is transfusion dependent and you follow the general rule of 200 ml per kg transfusions per year, that is an option, except for the fact that it has been shown in NTDT that doing a splenectomy actually accelerates the onset of pulmonary hypertension in this group of
Okay.
patients. So that is why you do it a little bit more carefully as compared to if you were treating a thalassemia major.
Depending. Okay. Noted, sir.
So that is why
And not,
there again there is
yes.
a question of doing a transplant if there is a matched sibling donor in those who have failed 2 lines of medical therapy.
Yes, another thing is that
Okay.
Dr. Vijay rightly pointed out that pulmonary hypertension, another thing is that there is a chance of increasing thromboembolic manifestation
Thrombosis.
also, right? So in the after the splenectomy, there is increasing
Correct.
incidence of the portal vein thrombosis and the thrombosis in the other part, because you are removing the spleen and you are not able to filtering this the nucleated RBC and the deformed RBC. So they are more microparticle will be generated that lead to the thrombosis. I think this too is the very caution as Dr. Biju rightly pointed out. So
Dr. Joseph,
I think Jojo is not active. So any question or any comment, Dr.
any
Sipla,
question?
your last comment or any?
No, he's coming on.
No,
No,
I
sir,
was there
everything has
only.
been discussed
Dr.
already.
Joseph, any comments, questions?
No, it is done well. You have done a great job, and all the questions in the chat box was also taken up, right?
Yes, sir.
I think
Oh,
Dr. Chandran has said transplant role not discussed. Like we said, we would definitely consider medical therapy with either hydroxyurea or thalidomide or a combination. If despite these patient continues to be transfusion dependent, there is still an option of a transplant. I would say provided there is a matched sibling donor, I would not venture into alternate donor transplants. So it's a question of discussion with the patient. Remember that these patients are likely to be older, and so the risk and mortality is likely to be higher. So transplant is usually deferred for the end and not upfront for these group of patients. So I think let me just check. Now that there are no further questions. Okay, thank you so much, Dr. Supratim, for your presentation, for Dr. Tufan and Dr. Shipla for the discussion. Very interesting case, but like you said, I mean, in the NTDT, this is something we see. There have been patients who have come saying spinal tumor, lung mass, whatnot, and they all present with extramedullary hematopoiesis. Just a question of remembering that that is a differential for patients who come with NTDT and have some sort of something coming out of their spinal cord. This is something we need to clearly remember. So thank you so much for your presentation and the discussion, and we'll hand it back to Inter.
Thank you very much,
you.
sir. Very good.
Thank you, sir. So, good evening, everyone. As we come to the end of today's session, on behalf of Intas Pharmaceuticals, I would like to extend my sincere gratitude to the entire team from NRS Medical College, Kolkata, for their valuable participation and contribution. My heartfelt thanks to Dr. Supratim Ghosh for his excellent case presentation and to Dr. Shipla Roy for her insightful discussions. I would also like to specially acknowledge Dr. Tufan Kante Dolai for his crisp and meaningful summary that added great depth to today's learning. My sincere thanks to our course directors, Dr. Biju George and Dr. Joseph Zone, for their constant guidance and vision behind this initiative. And finally, a big thank you to all the viewers for your continued support and active participation. We look forward to welcoming you again in the next episode. Till then, thank you so much and have a wonderful evening.
Thank
Thank
you
you,
so
thank you,
Thank
thank
you.
you, everybody.
Thank you. Thank you.